Last but surely not least, we have Dr. Sylvia Hafliger. And Dr. Hafliger is the Assistant Clinical Professor of Psychiatry, Texas Medical Center, McGovern Medical School, UT Health in Houston. And she's going to talk to us about how to prepare for a liver transplant.
So I'm the last speaker, and I'm wondering, I know, you guys are done, you guys can go shopping afterwards. And it's sort of interesting, I'm the last speaker, and I'm talking about transplant, right? You all, I know, I see your face, all of you want to probably prevent transplant, and hopefully with the new medications we've heard about, these COX inhibitors and all, other medications, hopefully you will not need a transplant. I am a psychiatrist, and I have worked 20 years at the Center for Liver Disease in New York. I have worked 20 years almost in a Center for Liver Disease in New York, and I don't know why I came down to Houston, but I relocated just before Harvey came, and I don't know how 2 weeks before Harvey, and I'm like, wow, welcome to Texas. And then I don't know how you found me, honest to God, because I said, you know what, I'm going to take a break from transplant and work in a general clinic, and maybe, help mentally ill patients, and but you found me. So are any of you in the room waiting for a liver transplant? Do any of you have cirrhosis? Okay. So I don't want to, I have to bend down because this is my most, so cirrhosis, right? So is replacement of a healthy liver with scar tissue, fibrotic tissue. And so this is, again, you've seen it in other forms, but I use this model a lot because it kind of puts it in a three-dimensional picture, and you can feel it. So this is a healthy liver, swollen, fatty liver, shrunken, hardened, cirrhotic liver, and cancer. So liver transplant, again, sorry, I know we're doing tapes, but so just to kind of, and again, I use this in my office to help people understand. So if you imagine you have cirrhosis, right? So this is your body, right? The heart, your lungs, your diaphragm, and your lumbar muscles, liver. And the transplant means removal of the entire organ, all of it, all body, all of it was taken out. I know, I'm sorry.
No,
Are you helping? Yeah. So, to get a new liver, you have a family of a person who has a brain injury who donates a liver, and that liver comes with a right lobe and a left lobe, but as you see, no gallbladder. So for those of you who are waiting for a transplant, you will never have a gallbladder. You just have a liver, and you can either get a liver from a person who gives you an entire liver, or, as we can see, the little liver that could, if you have a family member that loves you, they can donate a piece of your liver, because that liver, not the bile ducts outside, the bile ducts inside, and the liver itself will regrow in about 6 to 8 weeks. So that's just to set the stage. Amazing, right?
That's very cool.
So I kind of have this liver with me everywhere I go. So how do you prepare for a transplant? Well, number one, knowledge is power, right? You guys are here, you gave 2 days of your time and you learned everything there is about your illness. Same thing with a transplant. Learn as much as you can about the center that you want to go to, what services are they going to offer, do they have a psychosocial team, what are their outcomes in general. The 1 year survival after a liver transplant is 92%. That means it's pretty good. It's not 100%, so 8 people don't make it after the first year, but 92 out of 100 will still live. When you go to a transplant center, you will be examined from head to toe. We are very curious about there's 3 phases of the evaluation: medical, psychosocial, hence I'm here, and financial. What a transplant team wants is they want great outcomes. They want people who get that new liver to live 10, 15, 20 years. So medically, we want to make sure you don't have anything else wrong with you. It's just the scarred liver. We want to make sure you don't have colon cancer. We want to make sure you don't have breast cancer. We want to make sure your heart is healthy. So your medical team will say, get a cardiac cath, get a stress test, get a mammogram, pap smear, the whole spiel. Financial, you guys go, oh, what do I need? My insurance is going to pay. Let me tell you, the most stressful part of a liver transplant recovery is your bills. And you're fighting with your insurance company because they are determined not to pay for anything if they can. So all these new drugs that you develop, I'm going to have to get lots of prior authorizations and probably sell my firstborn before I can give them to patients. So your financial coordinator is going to go through your plan that you have chosen, and none of us ever pay attention to what we choose, but they're going to look at your plan and see how much your out-of-pocket expenses will be. Most insurances will pay 80%, 20%. You say, well, it's not that much, but it can be quite a lot because transplant medications can cost up to $5,000 a month the first year. So it's kind of like, wow, I really need to think, what kind of insurance plan do I have? Do I need a secondary insurance to cover the 20% that I am not, that I'm responsible for? So financial evaluation is important. I would pay good attention to it because my patients afterwards talked a lot about the stress of getting bills after bills after bills. And then the psychosocial evaluation. You may think, what the heck? Why do I need to see a psychiatrist? What is she going to do? Is she going to read my mind, put me on a couch, evaluate my childhood? Why do I need to see a social worker? So I have one thing to say. Chronic illness destabilizes families and destabilizes your brain. And just like the medical team wants to know, are there any cancers? Can we fix a heart disease? As a psychiatrist or as a social worker, we want to know, are there potential problems that will surface after the transplant or sometimes as you're waiting for transplant? Problems such as depression. If people say, well, I had a depression once, well, it may come back later, right? If you are somebody who has had bipolar illness, prednisone is one of the main drugs we use after transplant to prevent rejection. Well, prednisone is not good for the brain. So if you've had a bipolar illness and then you have a transplant and all of a sudden you're manic, well, I'd like to know that beforehand. So again, the psychosocial evaluation is to prepare me and the social worker and you what to anticipate. So when you come to see, so since I'm a psychiatrist, I'm going to spend most of the time on the psychosocial evaluation, but when you come for an evaluation, you have to bring, number one, a care partner, a transplant buddy. And people say, well, I don't have anybody. I manage my illness by myself. Why do I need anybody? I can do this by myself. Transplant is a team event. It's a team event. First of all, you're getting an organ from a family who has been gracious to allow donation to happen. You need an organ procurement team that goes out into the country and gets these livers. So it's teamwork from the hospital to the home team. So you need to have a home team and you need to have a captain of the home team. And you come to all the medical appointment at the transplant center with your transplant buddy and with a notebook and a pen. And if you want to tape the session, tape it, because there's so much information that people are throwing at you that you cannot all absorb it. So I never see patients alone, right? So if they come alone, I know that A, didn't read the letter because it says you will not be seen alone, and that's already a red flag for me. And if they come alone, I send them home because most of the time when you see a doctor, 90% of the information goes in one ear and out the other. And you come home and you say, so what did the doctor say? I don't know. Everything is good, fine, nothing new. No. So you need to bring somebody, right? So you bring, and again, it doesn't have to be your wife, it can be your neighbor down the hall, somebody who takes responsibility. And as a psychiatrist, I don't need to see 20 people who come to your bedside and say, I'll take care of you, because I just need one person that takes responsibility. Because sometimes a lot of people saying that they'll do something, and then they're all busy when it comes to actually doing something. So it's the functionality of the support team that's important. So when you come to see me, for example, you come to see me, not that you will have fibrosis because you're going to take your COX inhibitor, no, the NOx inhibitor, and you won't progress, but you come to me, so I will first start out and say, hey, where do you live, right? I'm curious whether you live in a house or in an apartment. Is the apartment on the 14th floor? And then I'm going to say, do you have an elevator? Because if you have major surgery, you have a big incision, remember, we just removed this liver, we put in a new liver, climbing 4 flights of stairs, not okay, right? If you don't have a bedroom or if you're sleeping in somebody's couch or on the floor, not that great. If you have 20 parakeets, I'm going to tell you to get rid of the parakeets because it's post-transplant, you're immunosuppressed. So you don't have to get rid of your cat or dog, but parakeets, we've had somebody who had 20 of them. We said, that's a lot of birds. So I will ask questions about your housing. Transportation, you may say, what's this why is that important? Well, transplant is a journey, right? Putting in the liver is the beginning. Maintaining the health of that liver requires driving to the transplant center every week, twice a week for the first several months. Once the liver is comfortable, once the immune system has quieted down, you come less often. But at the beginning, when you're tired, you've had major surgery, you will be coming. And transportation, how are you going to get there, becomes an issue. Most people always say, well, if I'm on the transplant list and if I get a call, how quickly do I have to be at the center? Usually, we give you several hours, 3 to 4 hours to make it to a transplant center. So, but that doesn't mean you can be in Paris and then we have a call and because unless you're very rich and you can fly to wherever you are. So transportation has to be worked out. And if you are in an area where you need Medicaid transportation or when usually calls for an organ, an offer with a liver usually are made at night because during the day ORs are used for your cholecystectomy, for your scheduled surgery, and at night, or transplant surgeons recover organs, so you most likely will get your call at night, and you have to figure out how am I going to get to the transplant center if I can't get, my Medicare taxi. So, next step that I'm very curious about is health literacy. Most people in the United States are maybe very good at knowing their finances and managing, their job. But when it comes to knowing their illness, it is appalling. And doctors have done a very poor job at educating people. So I will ask somebody, what is your disease? And I don't want you to just say it's my liver. I kind of like to know a little bit more. And then I'm going to ask, do you know where the liver lives? And I often ask people to draw me where they think the liver lives. And most often, people kind of draw it down here. It's not everybody knows, it's living right under, you point there. But not everybody knows that because unlike the lungs that we can feel, unlike the heart that we can feel, you don't feel your liver. You don't know where it lives. You don't feel the cirrhosis developing. It takes, before you have symptoms, 80% of your liver is replaced with scar tissue. You have no pain. It's not like, oh my God, I'm having chest pain, let me go to the doctor. Oh my God, I'm short of breath. No, silent disease, you don't feel it. So people don't know that they have where the liver lives because it never gives them a problem. You may know, but the majority of the patients don't. So I usually ask a little bit about their illness, when it was discovered, to give me a sense of what their literacy about their health is, right? Next focus of my assessment is then, when we talk about their medical condition, well, how did you manage it, right? What are the medications you had to take? And for me, and those who know me, I'm a kind of crazy lady. I really want to know what the medications you are taking, and you have to show me a list, right? A medication list. And don't tell me, look in the computer, lady. It's all there. I gave the list to the other doctor. Why do you ask me again? Because you know what? The other doctor never put it correctly in the computer, or it sat there, a list that's 10 years old, and nobody bothered to update it. So I need to know that you know your medicine, and not just you, but also your care partner. And then I'm going to say, oh, what's this ursodiol for? Or what's this Lasix for? Oh, you're on Xifaxamine. What's that for? Not to test you, but to just have a sort of a sense, where are you? How much do you understand? Because how transplant works is basically taking medications every 12 hours for the rest of your life. You will always be on immunosuppression. And if you can't manage medications before, it's going to be tough. And so if I have to teach you how to manage medications before, I'm going to do that. But that's why I'm asking, do you have a medication list? And we actually send people home when they come without a list, because it's just a sense that you're not responsible, right? So we cover that. Next, it's usually an hour visit, right? And I talk fast. I kind of ask you about, do you have depression, anxiety, bipolar illness? And people are like, nope, I'm healthy. Nope, I'm good. And then I have to say, look, I am not going to not list you or say yes because you've had bipolar illness or you're depressed or you're anxious. I need to know, because I need to prepare that if you get a liver transplant and you are manic, well, I know that you know what to do. Or if you become depressed, I know what to do. Actually, people with liver disease, post-transplant and pre-transplant, have a high rate of depression, much higher than people without chronic medical illnesses. And it has to do probably with the inflammatory changes, liver fibrosis and liver cirrhosis changes the brain homeostasis. When the liver fails to clean your blood, you have higher levels of ammonia. Ammonia is an end product of protein degradation in the gut. So it goes to the liver. A healthy liver clears the ammonia, makes it water soluble. A sick liver is less efficient, so you're kind of walking around with higher levels of ammonia, and then the brain has to work really, really hard. And the stellate cell in the liver, they're similar to the astrocytes in the brain. I just discovered that the other day because I was like, because brain-body is usually disconnected. But cells in the liver, there are cells in the liver that become active that cause fibrosis. Well, we have the similar cell called astrocyte, and they are very active to take up ammonia, and they become a little bit overactive, and then they kind of form scar tissue in the brain, or become a little bit hypertrophied, and so these abnormal brain astrocytes then cause a lot of the hepatic encephalopathy or brain fog that some patients experience with cirrhosis. So when I ask you about your psychiatric illness, be open be open, share it, don't hide it, because again, it helps me prepare for afterwards. Substance abuse. Not that any of you are smokers, but if you are smokers, I would like you to stop smoking, because transplant is a journey. And when you get a new liver, you're immunosuppressed. And if you're a smoker, you are increasing your risk of cancer, graft, liver dysfunction, heart disease. And if you look at how well do people do after a liver transplant? Well, they do pretty well in general. But what do they die from? Heart disease, kidney disease. So smoking, we tell patients you have to stop smoking, and we help them how to do it. We don't want people to smoke pot either. Well, that's kind of a controversial topic, but in general, we would like all of you who go for a transplant evaluation will have to do a urine tox screen, and we're looking for cocaine, heroin or morphine-like drugs, and also pot. And most transplant centers encourage you to be completely off marijuana. Alcohol is a hot topic too. If I had primary biliary cirrhosis, and if I were a woman, I wouldn't drink. So, because alcohol, you look at me funny. Well, we see that, unfortunately, cirrhosis in women who drink is a growing silent epidemic. Women are drinking less alcohol than men in a shorter amount of time, and they develop intense inflammation and scarring in their liver. We have now seen women come to us at age 27 with fibrosis or full-blown cirrhosis from drinking since age 12. So again, it's adding risk factor to risk factor. If you have primary biliary cirrhosis or an autoimmune hepatitis, I would not, and I have a woman, and I'm a woman, I would not drink at all. We generally, transplant centers, like one drink maybe, right? But it's not every, I know, I see it, you're gonna, come on, again. It's just, you know, when I talk to people about drinking, they say, oh, it's one or two drinks. But when you really ask women, these drinks are big glasses or half a bottle of wine, and they take it because they can't sleep. They had a stressful day. The kids were around, you know, drove them crazy. And before you know it, you drink way more. And then alcohol is quickly metabolized, and then you wake up in the middle of the night and you can't sleep again and you're feeling anxious, so you're drinking more, and so it's a vicious cycle, and that's why we see 27-year-olds come in with cirrhosis. So anyway, most transplant centers do not want you to drink because alcohol is hepatotoxic, and not all people who drink too much will develop cirrhosis, but it is one major, rapidly growing reason why we transplant patients. Okay, so we've covered housing, transport, healthcare body, or transplant body. We've talked a little bit about mental illness, substance abuse. Then I say to people, okay, so you want a transplant. What's your path for transplant, right? Just going to a transplant center doesn't mean you get listed or transplanted, right? So let's say you passed, you did all the evaluation, you got the medical part, you passed it, you passed your financial, say, oh, great insurance, psychosocial has listed, says, no, there are no issues, everything is a go. Now you're on the list, right? On this national waiting list. Currently, there are about 17,000 people waiting for a liver in the United States. The United States is broken down into 11 transplant regions. If you live on the East Coast, like New York, or on the West Coast, like California, you are competing with a lot of people in your region to get the liver. So you're listed on a national waiting list that's overseen by an organization called United Network for Organ Sharing. I used to live and work in New York. That was Region 9, and the livers that became available in New York State, in that area, would go to the people waiting in New York State first. So in New York State, there were about 2,000 people waiting for a liver at any given time. So 17,000 in the country, about 2,000 in New York. New York got about 350 livers donated from families a year. So do the math. 2,000 are waiting on the list, and every day we're adding more people, but the organ donation rate has, for the most part, stayed the same. We get, in the United States, about 6,000 people a year whose family offers their livers. And it's kind of a bad statistic. We benefited from the recent opioid epidemic. So a lot of young people, unfortunately, overdose and have brain death. And so this year, organ donation has gone up to 7,000 livers. But it's still not making up for the 17,000 people that are waiting on the list. So that's why I say to patients, so what's your path to transplant? Simply being on the list in the United States is not good enough. And so they say, well, what do you mean? And so we talk about that there's different kinds of livers you can get. There's the living donated liver. So from the very beginning, when you come into my office with your care team, I kind of bring up the little liver that could, right? If livers are transplanted according to your blood type. So if you're a blood type O, you can receive an O liver. You only can receive an O liver from a living donor, right? Because an O liver can only receive an O. If you're an A person, you can get from a living donor an A or from an O. So if you are an AB, anybody know their blood type, by the way? What are you? You're A positive. So there's 4 blood types, O, A, B, and AB. O blood type is the most common, and O is the universal donor. A is the second most common. B is sort of kind of, the third. And AB blood type is the rarest. When people are put on a waiting list, we calculate how sick they are by looking at 3 blood types, blood tests: bilirubin, kidney function, creatinine, and clotting time. For those of us who work in liver, those tell us a lot about how sick you are. Bilirubin tells us, well, how good are the bile ducts? How open are the bile ducts? How well is the liver able to excrete bile? Creatinine, or kidney function, tells us when the liver is sick, it can affect the other parts of your body. So if your liver is sick, chemicals that communicate with the kidneys are kind of off, and the kidneys just don't work as well. So a protein that we measure is called creatinine. That keeps going up. The third value is called INR, or clotting time. A healthy liver produces proteins that help glue together red blood cells and make a clot. If the liver is replaced with scar tissue, you don't have the factory, you don't have the ability to make clotting factors, so your clotting time, the amount it takes to clot blood will increase, and that's measured in INR. And INR of 1 is normal, and INR of 3 means, wow, it takes you a lot longer to clot than a normal person. So we take bilirubin, creatinine, and INR and calculate a number that we call MELD score, Model for End-Stage Liver Disease Score. The scoring number starts at 7. It's a sort of a mathematical equation, and the highest number is 40. And so I say to you, what does a MELD score mean? Well, it's just a number. No, the MELD score predicts your risk of dying from complications from cirrhosis in 3 months. The higher the number, the greater the risk of a complication like a variceal bleed, the veins in your esophagus opening and bursting, infections in your belly, confusion. All of those, as the MELD score goes up, are higher, right? Those chances. So you said you're blood type A. You are listed in New York State. Pretend. You would have to have a MELD score of 38 to 40. Now, you kind of go, I know. But that really translates that Kathy will be yellow with a bilirubin of 20. Her clotting time will be at least a 3, and her creatinine, well, she may be on dialysis. That's the reality. But she could also be listed in Florida, where there are very many more people donating organs because they have little strokes and have no helmet laws. And, I'm sorry, but they have more brain injury. And so Kathy could be transplanted in Florida with a MELD of 25. You may think, not a big difference, but it's a huge difference. Huge. If you're listed in Texas, I was at a conference the other day where they talked about, we transplant people with a MELD of 30. It's like, wow, MELD of 30. That is beautiful. In New York, it never happens. In California, it never happens. So I say to Kathy, so you really want to wait for this perfect MELD allocated liver, or are you going to have a discussion with your family about living donation? And then I'm putting out flyers, and everybody who sits there thinking, please don't look at me. I don't want to be a donor. I love her. But anyway, I just need people to know that they could. There's another category of livers that people talk a lot, and we call those extended donor livers. And that's a tough concept to understand. So you can wait for a used Mercedes, right? It's a car, it's a Mercedes, it's kind of top of the line. Or you can wait for a used Toyota. So I'm sorry. Well, I have to somehow explain it to people. So an extended donor liver is a liver that is not exactly perfect. It came from a person that may have had a lifestyle you don't approve of. Prostitution, prisoner, HIV exposure risk is high. It could come from a person that is overweight, an older liver, patients who are infected with hepatitis C, I tell them, don't get treated for your hepatitis C, because with the opioid epidemic, we have a lot of hep C positive livers that can only go to people who are still hep C positive. But it would go as an extended criteria liver. So an extended criteria liver is like a Toyota. In New York, it takes a little bit longer in the winter for the car to get started. So you have to let the car run a little longer. That translates, you may be in the hospital 2 or 3 days longer, because these older livers or these extended livers take a little longer to work, but once they work, it's a car and it will drive you to wherever you need to go. So if you go to a transplant center, say to them, hey, do you offer living donation? Do you have a good living donor? What's your statistics? What's your extended donor percentage? How many do you do? And so that you can then choose. You have 3 choices. You are listed on the UNOS list, and it doesn't matter. You can take a living donor listed, you can take an extended listed. So it's not, you're just increasing your chances of getting an organ. Does that make sense? So if you're on the list, you want to have a plan. Then next part I try to teach people is I manage expectations. People always think it's like, okay, I'm getting a new liver and life is great. I say, yeah, you get a new liver. You're not confused anymore. You don't itch anymore. You don't have a risk of bleeding, and you don't have a liver cancer. But it's not a perfect life, right? It's a journey. And once you get a liver transplant, you get immunosuppression. And immunosuppression has its own baggage. Lifelong immunosuppression can affect your kidney function. So you and your creatinine will forever be friends, and you need to know what your creatinine is, because Prograf and cyclosporin, those are the only 2 drugs we most commonly use, are over long term can cause a slight kidney slowing or failure. Immunosuppression can cause cancer. So you and your dermatologist are going to be great buddies, because once a year you're going to go, or twice a year, you're going to go have your skin checked. Skin cancer rates are very high in transplant patients because the T cells that always kind of wander around and take away cells that are damaged from the sun, they are not functioning as well. So dermatology and you have to be on speed dial. You come to us if you have an autoimmune illness. Let's say you have autoimmune hepatitis. Unless we come up with better drugs, so primary biliary cirrhosis or primary sclerosing cholangitis, you still have those illnesses, right? I just replaced the liver. I just took out a scarred liver, put in a new liver, but the immune abnormality that caused the illness in the first place is still around. Yes, immunosuppression may change the picture a little bit, but the underlying illness that you had that caused the problem, I didn't totally fix. So we have to monitor for recurrence of your illness for forever. And to think about, when you come to a transplant center, you marry us, right? You're with us forever, because we want to make sure we know how you're doing, and we report it back to the government, and you have to keep in touch with us. So forever we are part of your life. So expectation management is that your illness is not cured with a transplant. You get another set of problems. Recovery after transplant depends on how well you are when you go into transplant, right? People always say, well, how long will I be sick? Usually I say 3 to 6 months. The better fit, the more fit you are, the more you walk. So next time when you park your car, say, hey, Sylvia said I should walk more. The more muscle endurance you have, the quicker your recovery is. People who can barely get out of a chair, I know you're all tired. I know, but sitting around does not make you less tired. I need people to be fit so that they can recover and within 3 to 6 months be back at work. We would like people to go back to work in 3 to 6 months. But the first 3 months, your job is to take immunosuppression, make sure your kidney functions are okay, make sure you don't get infections. So, I think I covered most of it. Yes, 4:30. So, but I'm open for questions, because I think for some of you, this is kind of new or different, or so whatever you want to ask. Okay.
The question is age limit.
Oh, age limit. The question is there an age limit? No. In liver transplant, there is no official age limit. But I have to say that if you're 74 and you want a transplant, you better be a 74 that walks a marathon. The younger you are, the easier, when I say 3 to 6 months, yes, it is easier for a young person to get out of bed, walk, and be back in full life. There are 74-year-old people that are looking incredibly fit, that are fantastic, they're good. We transplant them. We have 74-year-olds who look 90 or 80. And so it's not a number, there's no upper limit, but the older you are, the greater the risk of cardiovascular complications, strokes, heart disease. Even though you may tell me, I'm 70, I'm great. But 70 with cirrhosis is not the, and then when we take that liver out, all of a sudden that heart that kind of was protected because a lot of fluid is in your belly, that heart now gets so much more blood volume and has to work so much harder. And all of a sudden that heart goes, whoa, I'm not that good as I thought I was. And so congestive heart failure and heart disease are just high. So be a fit, preferably walking, skiing, 74-year-old. Next.
One of the questions here I have.
Yes.
So based on kind of a limit of livers, does it make sense to relocate to an area with a lower population where maybe you have
So every one of you who needs a transplant has the right to be listed in multiple regions. So in New York, we have 6 transplant centers. It doesn't pay for you to get listed at Columbia, NYU, Mount Sinai. No, because we're all the same region. But you could get listed if you live in New York, in New Jersey. You kind of go around, right? And then you want to think, okay, so if I want to go and get, none of us are Steve Jobs, right? Who lived in California, and where did he get his liver? Was in Tennessee. But he was able to fly to Tennessee, have an apartment, be there when the surgeon called at 11 o'clock at night saying, I have an organ for you. So yes, money, we kind of say, oh, money doesn't really matter. Yeah, money matters because you have to relocate and take your family. But yes, you could move to an area if you wanted to kind of, pick up and go. But some people, we've had people who were living in Florida who were able to make it somehow within the 3 to 4 hours up to New York. Like or they lived further, North Carolina and came up. So it's doable, but it's challenging, how to get your transportation organized.
Great. And we have a question on for Texas. Why is there no partial liver transplant, and will that change?
So Texas is an unusual state. I'm sorry. I don't mean this in a bad way. Living donation is done, it has to be learned, right? And so if you don't have a surgeon that is comfortable at doing living donation and splitting a liver, then you can't offer it. So in New York, we had Dr. Jean Imant, who did the first adult to child living donation in 1989, and he then came to New York, and in 1998 we did the first adult to adult living donor transplant, and then we needed to learn how to do it, and so we went to France. There was a surgeon who did laparoscopic surgery, so he was able, in living donor, partially with 5 holes, and the small incision in the middle, like this long, he was able to split the liver laparoscopically and pull it out in the midline. It's the skill of the surgeon that needs to be there, and a small transplant center who has a transplant surgeon who has never done living donation, you don't want to go there. You want to go to a center where we've done a lot. So California, New York, I think we were one of the centers that, and again, the numbers are not big. We've done maybe now 250 in the 10 years. So we're not talking about, it's so much, but that's why Texas does not have, because they don't have the technical skills yet. Texas also, not all hospitals in Texas have an integrated psychosocial team. I'm trying very hard, for example, to get into Memorial, where there's no psychiatrist. And And I think the impact on the brain from immunosuppression, prednisone, the surgery, hepatic encephalopathy is great, and the caregiver burnout is great, and you really need to look at transplant like you look at like cancer and offer a psychosocial program. When I was in New York, there was a program, NYU, and when people became delirious after a transplant, when they were confused, I said to the surgeon, so what do? I tie them down. I said, oh, you tie them down? I'm like, okay, I guess you can keep them safe that way. But tying down in 2018, when we have medications to help people think clearly and not become agitated and not hallucinate, I think that is important. So if you're looking at a center, kind of ask, what psychosocial support do you have? A lot of programs, a lot of patients who had a liver transplant have an enormous need to give back to the community. So there is a post-transplant support group, like your support group. We have a post-transplant support group in New York. They visit patients in the hospital. They're providing peer counseling. I think those things help people heal and empower patients and families. And not every program has that. So kind of, if you're choosing a program, maybe that's one of the things you're looking at. Okay, that's it. So I hope none of you need a transplant.
Well, thank you, Sylvia. I appreciate that. And I think you win for the props as far as the little liver that could. So.